So first and foremost, I'd like to say thank yous to people who helped me out with this. On the left is Jacinth Lampron, who we know is our trauma director at the hospital, who was kind enough to sit down and talk to me about this. The middle is Dal Kublik, who's one of our vascular surgeons and intensivists, also will be playing heavily in this. And on the right is David Arthur Spencer, who is the owner and creator of one of the new REBOA catheters that's coming out that hopefully we will see shortly. Thank you to Andrew, who helped me with my slides again. He seems to be the guy I keep leaning on. And of course, the people who keep me sane. So I was trying to come up with a funny title for this. I couldn't really do it, so this is a few of them. So, life-saving snake? No, not really. REBOA, the aortic constrictor. And then, of course, REBOA, because boaing once just isn't enough. Obviously, none of those were very good, which is why they're not in the actual title. So we'll start off with a case. This is a case that I did have. It was not at this institution, but it very easily could have been at this institution. So if you imagine you're at a civic resus, it's been a quiet shift, and then you get a patch 5 minutes away, you have an MBC coming. So you have a 25-year-old female that rolls into your resus bay. GCS 14 is probably being generous. She's tachycardic, she's hypotensive, and on your primary survey, you get down to her pelvis, you rock her pelvis, and it just, it's wide open, right? So you start getting on a binder, you start trying to get IV access, and of course, she loses her pulse. So in this case, we have massive pelvic trauma leading to an arrest. This is exactly what happened. We did a resuscitative thoracotomy, so she lost her pulse in front of us. She got cross-clamped, she got rocked, she made it to the OR, and then she died about an hour into her OR from massive hemorrhage, essentially, uncontrolled hemorrhage. So you think about this case, and you think, did we do everything that we could do? And I would pose the argument today that perhaps there's other things that we could do that may have benefited a patient exactly like this for survival. So the objectives today, of course, is what is REBOA. I was a little bit surprised, actually, when I spoke to a lot of people, especially staff, and I said, I'm doing a talk on REBOA, you guys should come. They said, what's REBOA? So that was something that I think highlights the importance of this topic, because I think that it is an important one for us to know about. In order to understand REBOA, we need to know where it's been, where it is now, and where it's going. And of course, is this something that we should be doing in an emergency department? As I like to do, I would like to tell you what the real objectives are. Do I really want to blow balloons up inside people in the emergency department? Probably. Is REBOA really here to stay, right? So is this just another flash in the pan emerging technology where it's really not going to add anything to our care and it's going to disappear? Or is this something that we are going to need to understand because it's going to be in our hands shortly? And is this something that should be in our emergency department now or shortly in the future? So of course we have to understand what the problem is in order to talk about things to fix the problem, right? So why do we care? So this number 60,000 is an old number. It actually came from a paper in 1995, but if you look at the numbers, they haven't changed very much at all. 60,000 is the number of people who die in the United States from trauma, primarily from hemorrhagic shock. That is a huge number. These are people who are dying from potentially reversible cause, generally from non-compressible torso hemorrhage. If you look at the numbers from a little bit more recent paper, so in 2006, you're looking at 40% of the deaths in hospital from trauma within the first 24 hours are secondary to hemorrhage, or the sequelae thereof, and 85% of trauma deaths are because of hemorrhage. So 85% of potentially reversible or fixable causes are caused by hemorrhage, and that's something that we are not good at fixing to this point. So, of course, again, we're talking about hemorrhagic shock, and this is, I'm by no means an Osler-phile, but one of my favorite quotes in terms of shock in general is that shock is a momentary pause in the act of dying. If you are in shock, you're circling the drain, and that's our opportunity to try and turn something around, right? This is the moment where we actually can do something to fix somebody. Does anybody know who John Collins Warren was? No? Okay. So that's good because I didn't either. So he was the first dean, I believe, of Harvard Med School, and he was one of the first surgeons that did an operation under general anesthesia. I think it was ether, but I can't remember offhand. So this is what REBOA is, and I don't mean to be patronizing when I say it, but if you go through it, it's very much intuitive. So resuscitative, it's somebody who requires immediate acute care. Endovascular, it's inside the vessel. Balloon occlusion, meaning you're blowing up a balloon in the aorta. You're blowing up a balloon in the aorta. So it's quite an intuitive procedure if you think about exactly what REBOA is. So this is not a new technology. So if you look back, so the one at the top there, you can see this is from the Korean War, in which a lieutenant colonel actually wrote a paper where he discusses 3 cases. Only one of those cases actually had a balloon occlusion catheter inserted. All 3 patients died, and he essentially said that both of these other patients should have had it. Both were from massive blast injuries in the Korean War. And he essentially was saying we should be using this technology. In '86, they developed a balloon called the precluder balloon. So this is something where they've already had a technology, an intra-aortic balloon occlusion catheter. So this is when they had a case series of 15 patients concurrently, which included some trauma patients, some AAAs, and they found that they actually did have about a 25 to 30% survival rate with people that they used it in. And some of the people that they found did die were delayed deaths. And the interesting thing here was that they had that balloon up for upwards of 90 minutes. So if you can imagine including the aorta for 90 minutes, there was some badness that came along with that. And then again in '89, so this was another case series. It was 21 consecutive patients. They had 6 who were in PEA who all died. They had, I believe, 5 PEA, 6 who were, these were all missile injuries, so all essentially gunshots or shotgun shots. And of the 6 who were hypotensive when they came in, so that was a systolic less than 80, they had about a 60% survival rate, so 4 of them walked away. And then they had about 10 who were unstable but still had pressure over 80, and they had about 40% of those walk away after they got a REBOA, or IABO in that case. So you can see that this has been around since the 50s. It was around in the 80s, and then it kind of disappeared. Nothing came from this. So the precluder was there. You can search online. You can actually see their approval from, I believe, the FDA to be able to sell it in the States, and it just never happened. I don't have a good answer as to why that disappeared like that. It has been used in Japan since the early 90s, but there's no prospective data. There's none. Up to this year, we have maybe some retrospective stuff. We have a bunch of case series, but we have nothing in terms of observational data, nothing that's prospective at all. So then in 2011, all of a sudden, it pops back up on the radar, right? So you're looking at decades later, and you can see that these guys used a swine model where they opened up the swine. They bled them upwards of 35 to 40% of their total blood volume, and then they put in a REBOA balloon, and they said, hey, does this actually change hemodynamics? And shockingly, of course it did. So they had better central perfusion pressures. So they were looking, I believe, both at brain and perfusion throughout, so using whatever measure of pressures you can find. And they also found less systemic disturbances. So you're talking about things like acidosis. You're talking about things like inflammatory markers. So they found that you put a balloon up when you were bleeding, and you've bled enough that you are in at least class 3 shock, they do better. So of course, we have to understand how to do the procedure, right? So we see it's back on the radar, and why don't we understand what we're doing here? So if you look here, so this is a pelvis. What you want to access with a REBOA catheter is the common femoral artery. And the reason that you want to do this will become clear in a moment, but the superficial femoral artery is no bueno, okay? You want to put in a line. So at the very least, you want to use the introducer needle from the A-line, so an 18-gauge introducer needle, get access to your common femoral artery, and then you either put in your actual A-line and upsize to another guide wire, which is an Amplad super stiff, so this is similar to ECMO. So these are just very stiff wires. They're very long wires. This one has a straight tip, but generally you're going to want to use a J-tip wire, okay? And then after you do that, you want to upsize to this giant friggin' sheath, okay? So this is from when I was at Reanimate in San Diego, so this is Joe Belezo, and this is what they used there. So this is a 14 French sheath that, remember, is going into the femoral artery, not the femoral vein. So we all put cortices, which at our institution are 8.5 French, into the vein. So this is something that if it doesn't make your sphincter tighten a little bit, it should, okay? So after you put the sheath in, this is the CODA balloon. So this is what they're using in interventional and what they're using in vascular surgery. So this is exactly what they'll use, is this CODA balloon. So you see that you insert it, you use it, the guide wire. So the guide wire runs all the way up into the proximal aorta, and then you're going to blow it up. The picture on the right there is, you can see they've deployed a stent. This is just for illustration, but you can see this one is below the renal artery, so this would be a different zone of the aorta, but exactly the same concept. Here you can see it exactly the way it would look, obviously in cartoon form. So sheath is in, balloon goes through the sheath, guide wire, so Seldinger technique, and then there are your three zones of the aorta. So you can see that the celiac to the renal is zone 2, zone 3 is below the renals, and zone 1 is above the celiac to the arch. And that will become an important thing because it matters where you deploy the balloon. So this is the new catheter that I was talking about. So this is called the REBOA catheter. It's by Time Medical. I genuinely believe this will be a game changer. So the difference of this is that, number one, it is 7 French. You need only a 7 French introducer. So that is like as many Frenches. So that's good, because, it does not need a guide wire. So you've already removed another piece that can both cause injury and cause complications while doing it. It's got a J-tip or P-tip already there. So you can see that in the bottom left. It has direct measurement markings on the outside of the catheter, which the coated balloon does not. So you can actually see how far you've inserted the balloon. And you can see on the bottom right there that it actually has a second port, an arterial line that you can use proximally. So here you can see this hole here. So that is proximal to the balloon, which means once you insert it, you have an A line to see what your systemic pressures are. It's genius, right? Again, I have no conflicts of interest. I'm not getting paid by Prior. I have had the opportunity to use this, not in humans, but inserting it into very high fidelity simulators, and it makes a lot more sense, and in my mind is safer. Again, just another view of it. Again, just another view of it. So you can see here, this is being inserted into the 7 French introducer, which is the same if anybody's floated a pacer. That's what we're using to float pacers generally at this institution. So it's not something that is unfamiliar to us in our While I was at Reanimate, I was fortunate to see many world-renowned people come talk. So Kenji Inaba is one of the eminent trauma surgeons or preeminent trauma surgeons in LA. And this was him sort of just touting the benefits of it. And you can see, so there they use a 16 French introducer, which again, I mean, you're essentially getting to a ECMO catheter, which is 19 French in the artery. So it's again, it's scary stuff, but it's for a purpose. After it's in, how do you make sure it's in properly? So this is something that's been contentious, but historically, what they would do is fluoroscopy, right? I don't know if anybody's tried to get fluoroscopy in our department. I haven't, because I think it would be just an exercise in futility. And it also is probably unnecessary. So here you can see this is an X-ray. Here you can see that it's in zone 3, which means it's around the pelvis, probably below the renal arteries. There has been some evidence to show that just externally measuring is good enough. And then if somebody is dying, you want to get them to the OR rather than waiting for your X-ray to come. And then there's some new emerging stuff showing that ultrasound is just as good, if not better. And I would argue that in our department, where we have extensive ultrasound training, that's probably our best option. This is one of the studies they did. That was a cadaver-based study. They had 10 cadavers. This was blind. So they used external markings. Again, this is the LA team. And they found that just doing external markings on these cadavers was good enough. Unfortunately, in the study, it doesn't say who exactly was doing it, if it was staff or residents, how many they'd put in. It just talked about how fresh the cadavers were and that they got the landing zone appropriately, meaning where the balloon ended up was mostly where they wanted it to be. And then 2015, they came out, they did a case series of 100 consecutive angio patients where they had the surgeons looking for both transverse and sagittal views of the aorta, and found that well over 90% of the time they could visualize in both views, and that when they were placing their angio balloon catheters, again, I think it was 91% of the time with ultrasound, they were in the correct place and could visualize. So in the hands of surgeons, and again, they didn't say how much training these people had. It was all subxiphoid view, which probably makes the most sense. But it seems like this is something that if you practice it a few times, you should be able to do. And then this year, they came out with another study where they had pigs Again, they really like pigs for REBOA for some reason. And they looked at both residents and staff trying to place the catheters in the pigs. And again, it was equivalent to fluoro, equivalent to external landmark. So it shows that ultrasound is an appropriate modality. We don't have any superiority or inferiority data. But again, this is one of those things where we're not going to get a whole lot of great data because it's not going to be a modality that will be used exceedingly often. All right, so now we know how to do it, but the million-dollar question is, does it work? So this is a look at a study they did in the late 1970s. So these were people when ED laparotomies were being considered. I don't know if anybody's ever even heard of that. We don't really do that anymore, right? And what they did was they looked at 51 consecutive patients, and the thought was, well, hey, if these people are hypotensive, they're going to get a laparotomy anyway, why don't we do an ED thoracotomy? We'll cross-clamp the aorta, we'll get them better perfusion pressures, we'll stop their bleeding, and then we'll take them to the OR. So, of course, they did 51 patients. They all got thoracotomies and laparotomies. That many people survived. So that was probably not a good thing to do, right? So again, this goes to show that thoracotomies are something we can do. Is this something that we should do? And I think in the right context, yes, but not for all comers. 2013 was the first time that we really see any published data on human subjects who received REBOA. So this is the team from shock trauma. Okay, and here you can see that they had 6 patients, and this was, I believe, over the course of a few months. So they did their retrospective data after they had their case series of these 6 patients, and then this is a big long thing. I only want you to look at this. So if you look here, the top in red is their systolic pressures before a REBOA was inserted. Below in green, directly underneath, is the same patient. So you can see every single one of them had a significant increase in their systolic pressures, including the guy who had no pressure. And you can see that that guy walked away alive. So 4 of their 6 walked away. So that's impressive, right? Again, it's 6 people. It's minimal information. And then the other thing here to look at is how long did it take to put the REBOA catheter in, and how long did they keep that catheter up? How long did they keep the balloon up? Now, I did go through the paper. It doesn't say, is this 4, 5, 6 minutes from the time that they arrived in the emergency department? Is this from the time they punctured skin? Is this from the time they decided to put it in? So I don't know. But either way, regardless, 6 minutes is better than the speed it would probably take to get somebody up to an OR. And I think that that's the point here, is that this is something that will temporize the problem before you go get it to a permanent fix. And the other thing is looking at the time of occlusion. So 70 minutes is getting pretty long, right? If you're in a zone 1, if you're stopping the perfusion to the entire lower half of your body and your gut, you're getting a little bit long in the tooth there. So this is the other study that came out. So this, again, was a case series. I believe they actually used trauma registry data for this one. You'll notice that all of these papers are coming out from about 4 different centers. Houston, Baltimore, LA, and Denver. These are the trauma places that we know in the States. These are the places that seem to be using it, and these are the places that seem to be having success. Whether that's because they're more aggressive or because they have the population that supports it, I don't know, but this is where everything is coming from. So in this study here, they looked at this retrospective data from the registry. So they had 24 patients who had a REBOA versus 72 who had a thoracotomy. If you look on the right side of the screen there, you can see that all the patients who had a REBOA placed, while CPR was initiated, so people who showed up without a pulse, none of them lived. If you see on the left-hand side, so the 17 patients who either had bad pelvic fractures or had a positive FAST, they had relatively good survival, and 3/4 of the people, of course that's only 3 people of the 4 who had a pelvic fracture, survived after having a REBOA, right? And if you're looking at 13, when 46% survival, so about 6 people of the 13 survived their intra-abdominal bleeding. So I think that that's still pretty impressive. Again, how severe were the wounds? Were they all penetrating? Majority of these were blunt, and you'll find that with REBOA, majority of the time in every study, it's blunt trauma. If you look here, so what's important is the number of deaths. So 90% of the people who got a resuscitative thoracotomy died. 62% of the people who got a REBOA died. Again, is this comparing apples to oranges? Is this because of patient selection? It's not entirely clear because we don't have that information available. We don't have the data. We don't have prospective information. But you can also see that half the people who died from a REBOA died in the ICU. So they make it to surgery, they get their surgery, and then they die. So is this because of some late sequelae of using the technology, or is this because of injuries just too severe to survive? So it's not entirely clear. The other interesting thing here is if you look at the course of the 18 months of the study where they did this, on the left-hand side there you can see the use of resuscitative thoracotomy, and on the right-hand side you can see the use of REBOA. So as they started to see results, you can see they actually started to believe in it and started to use it. And as they started to use it, they started doing less thoracotomies. So in these two locations, I believe it was Houston and Baltimore, they stopped using as many thoracotomies for what they believed to be probably the more useful technology. In London, they have a very different system. So they have a helicopter EMS, so that's their HEMS. They have physicians on board their helicopters, so they have the opportunity to do a lot more pre-hospitally. And if you remember that first slide, 35% of hemorrhagic deaths are pre-hospital. So obviously, if we're able to get them at the scene, then we can do more. So far, they've placed 9 REBOAs. Not all of those have been pre-hospital. I believe 4 or 5 of those have been pre-hospital. And they're getting, again, around 40 to 50% survival. They've all had a positive cardiovascular response. But again, we know REBOA helps with the hemorrhage. And you can see here, all of their deaths were not due to bleeding. So at the very least, they've stopped the problem that we haven't been able to stop, which is the non-compressible bleeding. And then again, evidence of harm, that's a good question. And we don't have great information on that, but we'll look a little bit more about that further. And you can see very clearly at the bottom there that they felt the benefits outweigh the risk and the harm. Great. So let's do it, right? It's going to be great. It's going to be perfect. So as my colleague Mike Ho might say, let's just hold off a second, all right? Just because we can do it, should we be doing it, right? And who do we do it? And that's the million-dollar question rather than the does it work. You don't like I think that's a 5-toed sloth? No? Okay, all right. So very important to remember here is REBOA is not a cure. So REBOA doesn't do anything. We can put this in the emergency department, turn around and high-five each other, but we've done the patient no favors. We've just delayed their death. All right? So we need to have something to do to actually fix the problems. This was a bit of an opinion piece from the Denver team, and this is in 2015, basically saying, who should we be doing this in? So this is their algorithm that they've developed. If you look at this here, there are the no-brainers, right? In their eyes, they feel that anybody who is dead, getting CPR, has no pulse, should be getting thoracotomies. They feel that anybody who's got a systolic pressure over 80 is stable enough to get to the OR, regardless of whether or not they're partial or non-responders, get them to the OR, right? So then you get this group in the middle, and that's where the murkiness of this really comes in, right? So you can see in column B there, if you have a pulse less than 60, and important to see here is that if you have a thoracic hemorrhage, REBOA does not even play into it, right? Because that makes sense. If you have an aortic injury, if you have massive bleeding that's not going to be controlled by a balloon there, or perhaps going to be made worse by a balloon there, it doesn't make any sense to be putting it in. So thoracic injury is out for REBOA. So then you look at abdominal hemorrhage, right? So if you have a pulse less than 60, or a systolic less than 60, should we be doing a thoracotomy, or should we be doing a REBOA? I suppose you could look back to that paper from 1979 and say, well, if they've got abdominal bleeding and they're going to get a laparotomy, it doesn't seem that thoracotomy seem to help them all that much. But that being said, we don't have prospective data, so it's hard to say that. Maybe we've gotten better at doing our thoracotomies now. Maybe they did more back then. And then you look at pelvic hemorrhage, and if you have a pulse 60 to 80, that is the one time where there's no question. So in their eyes, if you have a pelvic trauma, you're bleeding, you're hypotensive, and your pressure is not to the point where they're worried you're going to imminently die this second, and then the point where they don't feel that you're stable enough to get to the OR, that's when REBOA 100% seems to make sense. This is shock trauma's algorithm. So if you look at the way that they're doing things, so if you are hypotensive and partial or non-responder, right, so this is again getting into our class as a shock, you access their artery, right? So full stop. It's not saying you're putting in a REBOA, it's not saying you're doing anything else, it's saying you're putting in an A-line. And I am a big advocate for being an invasivist. I believe that flying blind is really not helpful for anybody. I think we should be putting in more lines. That's my opinion. That's the way I believe I would practice because I think more information you get, the better. And I think we can do it safely with minimal complications. And then you start looking, saying, okay, do you think that the aorta is injured with your chest x-ray? Yes, no. If yes, full stop, right? Thoracic trauma, we're not putting it in. No, looking for positive fast versus pelvic trauma, and then it's zone 1 versus zone 3, and then trying to get them to the OR as fast as possible. So this is, again, from shock trauma. This was very much a summary of exactly what they're saying. So who gets REBOA? Hemodynamically unstable blunt trauma that's not thoracic, and then probably hemodynamically unstable penetrating abdominal trauma, and they felt not for traumatic arrest. And again, so this is Kenji Inaba, and I thought it was interesting that while he was there, so this is directly from him, is that his feeling is that REBOA is well within the skill set of an emergency physician, and in most places, and in LA they're doing it, the ER docs are the ones who should be putting it in. And again, this is a contentious issue, and that's not saying that that is absolutely the right answer, but it's interesting to hear very well-known trauma surgeons in very high-volume places saying things like that. So knowing how to do it, knowing that it may work, this is the really important part of REBOA. REBOA can make things way worse. So you look at, and then again, another swine study, where these guys put REBOA balloons up for 30, 60, and 90 minutes, and you can see that in the 3 columns at the bottom. So on the far left there, you can see the inflammatory markers. You can see there's a massive increase as you increase your balloon time. All of them needed more pressors, again, to trend to more pressors. And interestingly, there was a significant increase in pulmonary congestion, and you can see a very clear trend towards more ARDS the longer the balloon's up. So you think about what you're doing for these patients, you need to be able to have something quickly at your disposal. Like I said, high fives aren't going to save a patient's life. You need to get them to an OR, and you need to get that balloon down. So these are the things that it can cause, right? So you can get critical limb ischemia leading to amputation. You can get artery transection and dissection, which would require repair as long as you can do it, and you can think that that would be in the aorta, which is a bit of a procedure. Probably the most lethal thing that you're going to get is abdominal catastrophe and just ischemia of your entire gut, especially if you're in zone 1. And of course, you might look like Pete Reardon and just have no lower body. I was looking for a picture of him. I couldn't find it. All right. So, again, so zone 3, you're going to perfuse your entire upper body, nothing lower. So the guys from Japan, and like I said, Japan's been using this for decades now. So this has been used since the 90s. And they looked at some of their data retrospectively, and this was over a course of many years. And they had, you can see, a large number of trauma patients admitted, 5,200. And then 24 patients of those 5,200, so about 0.5% of their trauma population, got a REBOA catheter primarily, meaning this was not after ED thoracotomy, this was not in the OR getting a balloon. And they had 14 people survive. So again, a little over 50%. And what they found is that of those 14 people, 3 of them actually had to get lower limbs amputated, which is a 21% amputation rate. So this is really not insignificant. Now, again, going back to this, is why are these people getting such high amputation rates? Is this because the balloon's been up? Is it the way that they're putting it in? Are they using cut downs or percutaneous insertion? Hard to say, but we just know that these people were, at least had the cojones to publish the fact that they're actually getting some badness from their procedures. Presented this year by some of the folks from Texas, showing that they had, of their 33 patients with REBOA, none of them had amputations, right? And they had essentially a 2/3 survival rate. They had problems, right? Everybody essentially needs a common femoral artery repair because you're putting a 14 French catheter into somebody's artery. So that's a no-brainer, is that no matter what, when you're taking it out in the OR with the presence of a vascular surgeon or somebody who does primary repair of arteries. And they also had 8 other patients with significant complications, but nothing that was lethal to them, right? And again, you think the longer you have a balloon up and you have stasis, you're going to get thrombus. When you take that out, you can get embolus. Getting a dissection at that area, again, just because of the balloon being up is not unheard of. And then angioplasty, just because you get stricture or any kind of changes to it. So of course, we always think about putting things in, right? We want to do things, right? At least I do. I don't know about you guys. But REBOA has to come out, and that won't be our job, but we have to know about it, and we have to understand that that's going to come down the line. And of course, these are all the other problems that can happen, right? So we talked about embolism. The repairs aren't necessarily going to be easy. Of course, you always think about a limb amputation. And then, of course, what about your lactate? What about your potassium? You have a balloon up. What if you blow these things up? It's like coming off of cardiopulmonary bypass. You flood the system with all of these things. Is that going to cause cardiac arrest? I don't know. That hasn't really been shown, but it's something that we have to think about and not ignore. Fantastic, right? So it's going to be in our department, right? Yeah. So there are a number of things that we have to address before this is something that is going to be a viable technology or a viable modality here at our center. First and foremost is who gets this, right? We have opinion. We don't have any kind of definitive evidence. So I can't tell you who should be getting this. We can always use Gestalt, and of course, first and foremost, always be a doctor. If you're at the bedside, it should really be up to you, or in concert with your surgical colleagues, because this is not a unilateral decision-making process. And then, of course, the other contentious issue is who's going to put it in, right? So you have to be trained in this. If you were going to use a 14 French system, that means you have to be able to put in a 14 French or 16 French if you're in LA introducer sheath. You have to be able to use a probably at minimum 1.5 meters long wire, right? Because the Amplatz wires are long wires. You have to be able to put your balloon in the right place, and you have to be able to blow it up and keep it in the right place, which again is a lot of things. So how are we going to train people initially, and how are you going to maintain the skills? Because arguably, we probably aren't going to have a whole lot of volume of people requiring this here in our center. And then who's going to do something afterwards, right? After we've given our high fives, who's going to take them to the OR, or who's going to decide what the next step is? And that has to be something that's set up in advance before we have this. And certainly we have to have a QA program to make sure that we're doing it well and make sure that we're actually doing good rather than harm. So when I sat down with Dr. Lampron, certainly, and I agree with her, she said, REBOA requires a word of caution, right? We're all very excited for new technologies. We're all excited for patient-centered outcomes. But there's a lot of things that need to be in place before something like this can happen. And certainly having our trauma teams involved is first and foremost, right? In her eyes, this is something that should be done in consultation with the trauma team. And I think that's probably reasonable because you need to have an OR mobilized and you need to have these people moving as soon as you have that balloon in. The whole point of getting the balloon in is to get them to the OR. It's not to get them to a scanner. It's not to get them to angio, although angio may be exactly where they need to go, so that would be the other consideration. And they do have a hybrid suite here, which is an angio-OR hybrid, and that's probably the best place to get them. The interesting thing in Japan is that they have ER docs who are trained interventionalists, and they have angio suites directly in next to their ERs. So you can come in, get a REBOA balloon, and get an artery embolized within 15 minutes of arriving to their department, which I think is incredible, but of course never going to happen here. So the other thing that she thought is we probably have other trauma principles that we can improve before we start doing things like this, and I also agree with that, right? I think the amount of time that we are all exposed to various procedures and various significant traumas requiring heavy resuscitation is probably limited. So, maybe we should be getting better at putting in things like cortices and giving blood faster, perhaps having more practice with chest tubes, and I think that all of those things are probably reasonable, and I think that the amount of time that we go in between doing these procedures is quite long in this institution, so maybe we should have more task training. I would look to my SIM colleagues to take that under advisement, right? When I sat down with Dow, I didn't sit down with him, I talked to him over the phone, but it was interesting. So, I don't want this to be taken as him saying, oh yeah, you guys should definitely be doing this. His thought was, well, you know what, I've had AAA patients where I've actually had to bring down a balloon. He's never had to put one in, but he's considered it because you have unstable patients. So why don't we at least have a coda balloon in this department? He says, you know what, it's like putting in an A-line, and I do agree with this. It's not foolproof, but this is not a procedure that is technically difficult, and you're talking about dying patients. So if we have the modality available, We may be able to save a life. I think it's unlikely that we would do more harm in the short term. Of course, that's entirely opinion, and certainly there are opportunities for that to happen. But he said, why don't you take a coated balloon 6 months before it expires, you send it up to the OR, we send another one down, and then at least you have it in the department, which is probably not unreasonable. In his eyes, as a vascular surgeon, he says, if you put in a big sheath in somebody and they're dying and you can pull it out and they survive and they need an artery repair, he's like, absolutely, call me, that's totally reasonable. Right? So, that from the vascular surgery perspective, and then from the ICU perspective, it's trauma principles. So he says if somebody's dying, you have the ability to save them, this is not an unreasonable modality, and he thinks that this is something that the ER doc should be putting in or have the capacity to be able to put in. So when you look at some of the PASC trainers or sim trainers that have been designed, there are some out there. Again, we don't have infinite funds and we don't have infinite time or space, so not all of these are possible, but you can see that they have designed both cadaveric models in which they actually perfuse the cadavers, and you can imagine that those would be a little bit extensive. And then some other task trainers where you can insert the balloon, try to make it somewhat realistic. And again, if you saw the model that we were using at Reanimate, Zach Shiner actually built some of them in his garage, and they're quite phenomenal models, both for vascular access as well as for procedural practice. Multidisciplinary sim, you can see here, is blank because there is literally nothing, at least on this modality, that exists in the literature. Right? So this is something that we talk about a lot, in situ sim. And this is probably one of the beautiful things that we could do with our trauma team is saying, hey, why don't we have models where we can actually practice putting in a REBOA? And I think that the reality is if this technology came to TOH, we would have to have something like that in order for it to be effective. So now that we know all this, we say, Noam, what are you talking about? You said you want to do it, and then you said you didn't want to do it, and what are we going to do? So it's a good question, right? So this is the American Association of Surgery and Trauma team. So they actually have a registry that's being built. So this is Joe DuBose, who has just published some of the observational data. So they're starting to try to get some prospective stuff. At least observationally, it's not going to be randomized. But this is essentially saying, we have this database. Every time that you put a REBOA in, please tell us about the case, and we're going to collect all the information. And there is a plethora of various characteristics that they're recording. If you're interested, I recommend you go look at it online, because they're trying to collect as much data as possible to see if this is an effective modality. And I give kudos to them for trying to see what's going on nationally and internationally. The other thing that I think is really interesting that's coming is partial REBOA or intermittent REBOA. So if you compare this to something like a tourniquet, right, we know that if you have a tourniquet up for 4 hours, it's probably not very good. But what about if you have it up, then down, then up, then down, then up, then down? So you're intermittently perfusing. You can maintain some of your perfusion pressures, and you can actually get fluid resuscitation initiated. So they've looked at this in a few different ways, right? So this initially was just what their concept of it was, and again, you can see Joe DuBose as being part of this group as well. So what they're saying, basically, this is the ER prior catheter, which has the proximal A-line, and then they say, why don't you put a contralateral A-line, so you can do essentially a normal tensive resuscitation up high and a hypotensive resuscitation down low, not a non-tensive resuscitation, right? You don't want to completely occlude the flow, but what you're doing is essentially permissive hypotension distally, and you're still perfusing your kidneys, you're still perfusing your spine, you're still perfusing your gut. So another team took a swine model of this, said, hey, why don't we look at this? This was actually this was a human case study, and what they did was somebody who had a gunshot, and they had the balloon up, and you can see the total occlusion on the top left there. So they actually blew the balloon up, they got his pressures to 120, and then they slowly started taking the balloon down. So what they were doing is essentially in the OR going balloon up, balloon down, balloon up, balloon down, not completely up, not completely down, but trying to find a sweet spot where they're getting at least more proximal perfusion to maintain this guy alive. And you can see ultimately they got the balloon completely deflated and actually got him out of the OR. So this is something that may be very effective. And in this instance, that was only 30 minutes, but you can imagine if you're in the periphery, if you're coming from Arm Prior or Winchester or something, you have a bad pelvic trauma that's not going to survive the trip over here, you put a REBOA balloon in. If you put a REBOA balloon in and leave it up for an hour, hour and a half, they're probably going to die. It's just going to be a more prolonged death. But if you can do this, then this actually may be an effective way to get somebody from the periphery into this hospital. Now, this one is interesting. So this is the swine model. And what they're doing is they have found a way to build this machine, which looks crazy complicated to me. And what it is essentially a real-time sensor of perfusion pressures. So what you do is you put the REBOA in, you put this thing on, and somehow it calculates what the pressures are and blows the balloon up accordingly. So if you think of it somewhat like a balloon pump, it's just a real-time balloon pump that's constantly evaluating what's going on and changing accordingly. I can't imagine something like this is very cheap. It certainly doesn't look in this form to be something that is viable in an emergency department, but as an emerging technology, this is interesting and maybe something down the line, if they can miniaturize this and actually be something portable, would be interesting to have available. And of course, we're talking about traumatic bleeding, but this is something that could actually be quite effective in other non-trauma bleeding. So this case from Japan, and a lot of case summaries are from Japan, or case reports. So this is a lady who lost 7 liters of blood following a C-section. She just had atonic bleeding that was really non-responsive to any chemical therapy. She got 34 units of blood, 38 of FFP, so you can see she got a shit ton of blood. And they actually left her arterial sheath in place for 24 hours. And this was a 7 French system, and then took it out and had no complications. So this lady lost 7 liters of blood and survived. Walked out of the hospital, I believe, something like post-op day 10. This is another case, ectopic pregnancy. Again, she had 3 liters of blood in her belly. She got a whole bunch of blood. They couldn't get her to the OR because she was too hypotensive and kept losing consciousness. And then again, she left the hospital post-op day 8 with no complications. And of course, there's other things we can use it for. So interestingly, upper GI bleeding. So this is a case series from Japan. I didn't actually put any of the data in. It's a bit of a messy paper, and I actually had trouble deciphering it. But the point is that they had about 21 patients over the course of many years of 140 upper GI bleeds, quite significant bleeds, where they were finding some efficacy in trying to tamponade the bleeding in people who are refractory to any other treatment. So this is, if anybody's heard about this case, so Matt Duma is a nurse. He works with Peter Brindley out in Edmonton. So this is Matt, lovely guy. So Matt happened to be around the street when a young guy got shot. And he got shot, I believe, in the thigh, in the belly, and maybe in the pelvic area. And he was one of the first on scene, and the guy kept passing out and going pulseless. So what Matt did was he made a fist, and he pushed on his aorta. He pushed externally on his aorta, and the guy woke up. So he basically is like, oh, okay, great. And then they had bystanders. He's like, okay, I want you to just push on the aorta, and I'm going to go try and help with the other things. Somebody who was less hefty than him, went on the aorta and pushed on it, and then the guy passed out again and started bleeding profusely from all his sites. So then Matt came, got back on, and he pushed on his belly, and then the guy woke up, and he stopped bleeding. So the point of this is that, so this guy actually survived to the hospital and ended up dying in the OR just because of the problem. But external aortic compression is another mechanism and another modality where we can consider ways to tamponade bleeding, right? So instead of doing internal tamponade, you do external tamponade. And you can also think the problem with this, when you're pushing with your hands, is the same problem with CPR. When you're an EMT and you have to move this guy, trying to lift him up, there's no way that you're going to be able to push on this guy while you're lifting him up. So of course, you're going to go through these periods where they're going to bleed or get sick. So what do I want you to leave here today thinking about this? I think that REBOA is clearly effective. It's shown in every model and human instance that it definitely increases your perfusion pressure. I believe that it's safe if used appropriately. And again, you have to have the ability to get things done downstream. And I believe that it's here to stay. I think unlike in the 1970s and 80s, this isn't just going to disappear. I think that this is going to be something that they're going to make better, and that this was something that we will definitely be seeing in the future. REBOA doesn't fix a problem. REBOA temporizes a problem so you can get them for a fix. I think that's a very, very important point that has to be made. Similar to intubation, similar to things like ECMO, It doesn't fix the problem, it buys you time. And then you have to fix the problem. And certainly having a downstream system where we can get them where they need to go fast and effectively and efficiently is vital. The ED is exactly the place where REBOA should be. This is the place where it's going to be used. This is the point, is that we're putting it into patients so we can get them to definitive treatment. It may be useful in other places like the ICU or the OR, but if you're talking about trauma and you're talking about refractory bleeding, this is exactly where we should be using it, and we should all be knowing about this, and I think that this is something that, as it gets better, is something that we all probably should be trained in and be using eventually. And certainly the emerging technologies, again, not just the REBOA catheters, but things like external compression and the variable balloon monitoring are going to be getting better. And the ER REBOA catheter from Pride Time is not yet in Canada. I did speak at length with David Arthur Spencer. It's about $2,000 US for one of the catheters. It's not yet approved in Canada. It probably will not be, I imagine, for at least another couple of years. I think if we were to use a system here, the 7 French system would be what we should use. I think trying to train 80 plus physicians, 70 to 80 residents in a 14 French guide wire assisted system is probably not realistic. So I don't think that that's going to happen today, but I think within a couple of years, this is something that will be at our center. If there are any things that were not addressed here, please follow up on Facebook. Thank you all for your time.